Maryland's correctional facilities now operate as large medical triage centers, forced to manage a constant stream of specialized clinical needs behind bars. People frequently arrive in custody carrying severe, untreated health burdens. Jails are actively managing active psychosis, severe opioid dependence, and advanced unmanaged chronic conditions. The immediate problem is the physical space itself. These structures were engineered for maximum security confinement. They were never designed for the rapid, sterile delivery of modern healthcare. That design creates constant operational friction. If a person needs an evaluation for an infection or active withdrawal, they can't just walk down the hall. Every movement requires coordination with limited custody staff and physical escorts. Forcing complex medical care into rigid, punitive architecture guarantees systemic delays. It turns routine healthcare delivery into a relentless logistical crisis. That logistical crisis escalates as the population ages. Maryland's state budget materials for 2026 specifically track a growing cohort of older, medically frail people currently living in state custody. This demographic requires entirely different baseline accommodations to survive. They need wheelchairs, walkers, oxygen tanks, accessible showers, and lower bunks. Try maneuvering a wheelchair or an oxygen apparatus through these narrow cell bars and outdated, cramped walkways. The infrastructure physically rejects the equipment. Because the buildings cannot support geriatric care, aging people require far more outside hospital visits and specialty consultations. Every trip outside the walls pulls correctional officers off their regular posts, heavily straining an already thin staff. Maryland is actively acknowledging this breaking point. The state has decided to close the aging Maryland Correctional Institution at Jessup by June 2026, explicitly citing the need to reduce strain on staff and aging infrastructure. Keeping medically fragile people inside facilities built decades ago creates an unsafe environment. The state ends up spending its budget on inefficient, cumbersome logistics instead of actual patient healing. Beyond the physical constraints of the architecture, the system is also pressured by the high-stakes management of acute mental health crises, trauma histories, and active substance withdrawal. Managing those conditions requires navigating a divided bureaucracy. The Department of Public Safety oversees general facilities, while the Department of Health manages in-house hospitals. When patients move from intake to housing to sick call, they bounce between jurisdictions, creating dangerous bottlenecks at every transfer. When paperwork and staffing shortages slow these transfers down, the human cost compounds. Untreated depression, psychosis, or suicide risk rapidly escalates into self-harm, facility violence, and severe health crises. Maryland relies on channels like the Office of the Correctional Ombudsman to track these failures. Because an incarcerated person cannot freely choose to see a different doctor, independent audits are the only safeguard to identify when delays become dangerous. Layering a fractured oversight system on top of severe staffing shortages takes manageable behavioral health conditions and turns them into expensive, life-threatening emergencies. All of this internal pressure eventually spills outward. A person's medical journey does not end the moment their sentence is finished. Many people walk out of custody carrying the exact same unresolved illnesses they had inside. They leave with chronic conditions that need immediate attention and disrupted medication-assisted treatments. If release planning is weak, continuity of care completely breaks down. Prescriptions go unrenewed, clinical follow-ups are missed, and the risk of immediate substance relapse spikes the very first day out. Those newly released individuals fall straight into medical crisis. With nowhere else to turn, that burden is immediately offloaded onto local emergency rooms, draining community public health resources. Maryland lawmakers are tracking these systemic failures closely. The policy and budget debates happening right now recognize these gaps as both severe ethical lapses and massive fiscal liabilities for the entire state. Treating correctional healthcare as an isolated issue doesn't work. The only way Maryland can prevent these unmanaged crises from spilling over into costly community emergencies is by finally fixing the care provided inside.